First, we're going to welcome our opening panel of the day, which is looking up at an issue that's very much constantly, I think, in the news, the levelling up agenda, but levelling up through partnership and collaboration when it comes to NHS providers. So we've got about 45 minutes on this, and a bit of an opening with our speakers giving some of their thoughts, then a chance to ask, have a discussion and ask questions. So what this session is about is exploring existing approaches, including anchor status, the emphasis on place-based working, and the oversight role of integrated care systems. But we also want to ask questions about how the NHS works, both at scale and with local relevance. So we want to explore the economic role of the sector and consider how strategies for investment, procurement, and education can contribute to a more sustainable future. Our panel can also offer us perspective in how we focus greater attention to traditionally excluded communities and geographies. And I will say, thinking of geographies, I was saying to all the panelists this morning, the FT is a big piece about Bradford and the impact on that if they don't get this kind of HS2 extension, and how a whole city and its inequalities are all related to all kinds of investment. So our panelists today are Dr Owen Williams, who's Group Chief Executive of Northern Care Alliance, Toby Lewis, Senior Fellow of the King's Fund, Matthew Taylor, who's Chief Executive of NHS Confederation, and Patricia Miller, Chief Executive, Dorset County Hospital NHS Foundation Trust. Good morning and welcome to all of you, and thank you so much for joining us. So I want to ask each of the panelists to start by sharing a few reflections, just for about 3 minutes, on how we focus greater attention to traditionally excluded communities and geographies. And I'm going to ask Owen Williams first to share your ideas and views on working at scale and focusing on tackling exclusion.
Thank you, Samira, and good morning, everybody. Hello, my name is Owen Williams, and I'm 10 days into my new role as Chief Executive of the Northern Care Alliance NHS Foundation Trust, which is a part of the Greater Manchester Integrated Care System. Some of you may know that prior to this, I was the Chief Executive of Calderdale and Huddersfield NHS FT, based in the West Yorkshire Integrated Care System. So you could say I've kind of defected from white rose to red rose country, but that's another conversation for another day. I've been asked to direct my brief 3 minutes towards answering the question of how we can work at scale to tackle exclusion, levelling up, or as I would say, tackle health inequalities. And I guess for me, whether we're talking about organisational scale or vertical or horizontal system scale, the first question I would ask at any level is, to what degree would you know as a leader that your organisation or system doesn't already exacerbate health inequalities through its everyday custom and practice? And I guess as a leader, this is a question I ask myself every day, and I have the natural curiosity to want to find out and respond based on what gets identified. However, through my organisational system work and some of the work I've done at a national level, it has been my experience that this is not a routine thought process for some leaders within the NHS, or for that matter within local government, particularly those who have the ability to influence at scale. So together with colleagues at NHS E&I, we developed an acronym which we call SHORE, just to help stimulate thinking. And the S of SHORE, or the SHORE acronym, stands for having the ability to see health inequalities in the first place. And this is not just about relying on traditional approaches such as joint strategic needs assessments, but it's about understanding at a granular level how your everyday organisational or system practice impacts on health inequality. The U for understanding really is about, and reflected this particularly in my previous organisation and across the West Yorkshire ICS, the combination of seeing and understanding has kind of led us to collectively conclude that through our day-to-day practice, we were and still do exacerbate health inequalities, which prompted us to enact the R of the SHORE acronym, which is about responding. And I guess just reflecting on the West Yorkshire context, the necessary responses have been varied depending on the context of what we've seen and understood, and have ranged from focusing on education and shared definition of what we mean by health inequalities, better data capture, through to accelerating digital capability, which are all fundamental aspects of being able to see and understand and respond to health inequalities. And most significantly, in an NHS provider context, changing clinical multidisciplinary practice and behaviour to make sure that that day-to-day practice actually promotes health equity as opposed to health inequality. And I guess this has created the conditions for us to evaluate, which is the E of the SURE acronym. And without doubt, if we pay attention, proper attention to health inequality, we can make a positive difference to the communities that we serve. So I'll stop at this point, as I'm sure we'll get a further opportunity to explore throughout this morning's session. Back to you, Samira.
Owen, thank you so much. Patricia Miller next. I think you can particularly reflect on the contribution, on areas that don't fit the levelling up definition, which you often tend to think of as being kind of, urban areas. Tell us a bit more about the challenges.
So thank you, Samira. So my name is Patricia Miller. I'm the Chief Executive at Dorset County Hospital, but I've just also been appointed as the Chief Exec Designate for the Dorset ICS system. So this is obviously front and centre of my thinking at the moment around how we as a system develop a strategy around levelling up. I think for context, for us it's much wider than just what the government talk about, which is predominantly HS2. It involves all the wider determinants: housing, education, employment and health. And it involves eradicating the disadvantage for the core reasons that we recognise and talk about every day that are built into the Equality Act. And that might sound like an impossible task, but it is how we evolve into a fairer society where everyone really does have the opportunity to live their best lives. And I think what we find in coastal and rural communities, because again, the national conversation tends to move this into the space of north and south. And as a northerner, I can say now living in the south, it's not simply about north and south. There's also a really big issue in coastal and rural communities. And some of those communities have got the highest levels of deprivation in England. And we know that if you live in some of those areas where deprivation is high, that you would have to spend somewhere between 2/3 and 3/4 of your weekly income in order to eat healthily. So this idea that people are poor and it's their own fault, actually there are structures and systems in society that keep them there. And if that's the situation that you're in, you are regularly making choices for your family between food, heat and rent. So increasing employment opportunities and therefore increasing household wealth and social mobility is absolutely critical for some of those communities. For me, there are other dynamics that come into this, which we talk about in our system constantly. Rural deprivation is deep and wide. Transport infrastructure means that individuals and families can't access the support they need to improve their health and well-being. And, we've just had COP26, a really great example of how environmental sustainability, if we take it seriously, can really contribute to this agenda. It improves the health and well-being of populations, it increases employment opportunities, and particularly in seaside areas, we know that if you look on the surface, what appears to be full employment, actually, when you go deeper, is mostly 0 hours contracts related to the hospitality industry. So we've got to find ways of creating different employment opportunities for those communities, not just because it increases household wealth and social mobility, but because it also then keeps younger people in the population, where in areas where some of the most aging population lives. In Dorset, as an example, we have the oldest population in England. So retaining young people to support long, healthy lives for elderly people is critical. But I think the final reflection for me is that ICSs have a massive role in this space. The NHS is the biggest anchor institution the UK has got. Local government organisations also play a massive role in that space. And we have an opportunity to really move the levelling up agenda forward and take a huge role in the government agenda to change the lives of communities for the better. And to me, the critical element of that conversation is about putting communities in the leading space. They understand their own lived experience. They know what services we provide add value to them in terms of levelling up. And they also know what services we provide that provide barriers to them improving their overall well-being and life expectancy and life chances. So putting them in the front seat of leading some of this and co-designing the services we need going forward and co-delivering them with them, for me, is the critical element that will move this conversation forward and really produce some positive results.
Patricia, thanks so much. Can I just follow up on one thing when you talked about the barriers that we have that make it difficult for people? Have you got an example?
Well, I think that the health service in particular for a long time has taken a very paternalistic view to the development of health service. And the reality is many of us might think we know what's best for our communities, but we're not living their lives. And so for me, the engagement with communities as true partners in a way that has produced real success in Wigan is the way forward. It's listening to our communities. It is being very brave and being able to take on the chin areas of service where we think we're doing the right thing and actually we're not. And that's really difficult. If a service is your baby and you've developed it over 10 years and then you talk to your community and they say, actually, it has no value to my life whatsoever, that's a difficult message to hear. But I think we've got to have those really honest conversations so we can start to evolve the relationship into more of an equal partnership. And we're letting our communities drive the pace and the development of services that really add value to their lives.
Thank you so much. That was really, really helpful for you to explain that a little bit further too. Toby Lewis next from the King's Fund. I think you can reflect on the contribution of community co-production and anchoring for this agenda.
Thanks very much. When I was asked to talk about levelling up, I was slightly worried it was just another ready slogan, really, and the policies still not come out. So just a couple of reflections for me, having spent 25 years in the NHS. Trying, I think, to work in the kind of space that Owen and Patricia have been talking about. This isn't a why agenda, is it? We know if you're in year 6 in a deprived area, you're twice as likely to be obese. We know there's an 8-year life expectancy gap if you're female in the UK. We know that half of the people who live in poverty in this country are either themselves disabled or live with someone who is disabled. So it's not a why agenda. For me, Samira, I think it's a who agenda, exactly as Patricia's been saying. So the question for conference really is how one reaches invisible populations who are hidden in plain sight. And the pandemic has really brought that to the fore. But I think what it really requires us to do is to think about what Donna Hall will call community power, what I might think of as anchoring rather than anchor institutions, which is how do we really work in and with and through communities. And that's vital because we need to find a reach that gets to those populations. It may seem an extraordinary thing to say when we have ambulance queues as we do and we have the Daily Mail battering down GPs' doors, but actually this is an agenda about reaching people who are not putting their hand up for a traditional NHS service. But because this is a zero-sum game in the sense that if one is going to genuinely shift the dial into reaching those invisible populations, it necessarily changes what's offered to other people. Community involvement community participation then becomes vital to a trust dialogue because there needs to be an honest conversation about what we aren't going to do because this is more important. So it seems to me that the levelling up agenda and the situation we're in with inequality in the country necessitates community co-production of the kind you've seen a little of around Grenfell, as Patricia says, of the kind you've seen in Wigan. There's probably 3 things where this really matters greatly to health in the short term. First, it alters the workforce conversation. So if you're in Rowley Regis, you're sending out social prescribers as your home visiting team. If you're in Fleetwood, you're looking at community health workers model of what's been done in Brazil. You're looking at where you get your workforce from in terms of people who are at risk of homelessness, provided with housing in a hospital trust in Sandwell, and given apprenticeship access. So there's a workforce dimension. As Preston has shown us, and I know the NIHR study hasn't come out yet, but as Preston has shown us, there's an economic conversation. The NHS is rich. It feels poor very often, but it's rich. And it's about to become the public sector bank in local areas. So in that sense, there's a crucial question about how we spend our money. And I agree with the Health Foundation that when we come to find the policy, one of the tests is, does it genuinely shift us upstream? Does it get us into a place where we're talking about not even primary prevention, but underlying wider determinants? Secretary of State was right, and he took a battering for it when he says that the most important health service in some ways is the care that's provided informally at home. The NHS is the third most important health service in my judgment. That leaves the bit in the middle. Well, the bit in the middle is housing and employment, and somewhere between 44% and 56% of our health status is driven by those two factors. So the test of levelling up from an NHS point of view is when we meet at providers in 2 years' time, how much more of the NHS pound is being spent in the housing space, in fuel poverty, in provision? How much more of the NHS pound is being spent on widening and altering patterns of employment, not just for young apprentices, but for pensioners living in poverty? So those are the things that need to be done. But I guess my plea in closing is we're trying to cross quite a hard road. And if you're trying to cross quite a hard road, it's probably a good idea to look both ways. So yes, there's a large-scale infrastructure, HS2 being built on my doorstep in Birmingham conversation, but there's got to be a look the other way that looks at community participation right into the boardroom. And that's hard. Goodness me, we saw it was hard yesterday, didn't we? That's hard because it alters the power axis of how organisations are run. And we'll be back with the Black Report, we'll be back with Aitchison if we don't make a difference to that power dynamic. So it's not really about arguing about which trusts have a seat around the table. It's really about which communities have a seat around the table. Thanks a lot.
Toby, thank you so much. And our final panellist, Matthew Taylor, I think you're going to focus on the whole sector perspective and on how strategies for investment, procurement and education can contribute to a more sustainable future. Welcome.
Well, thanks, Samira. I just want to say at the outset, I think it's really important in all these conversations to make the point that Owen and Patricia have made, which is that when we talk about health inequalities, there's sometimes a tendency to say, well, when we talk about health inequalities, it's all about the contribution that services outside health, wider socioeconomic factors make. But it always feels to me as though the conversation about health inequalities has to start with the fact that the NHS's own practices are exacerbating inequalities, and we must never use this wider conversation about the wider socioeconomic context to distract us from the work we have to do ourselves to ensure that the NHS is not exacerbating health inequalities. I mean, for the Confederation, this area of the relationship between health and the wider society and economy has been a critical area for a number of years, both in terms of kind of policy and practice. And one of the things that we're doing at the Confederation at the moment is talking to our members about developing a set of impact objectives for the Confederation, because I don't think that, given the challenges that we face right now, that advocacy is quite enough for us in terms of what we need to be trying to achieve. So we're developing a set of things which we believe shifts, which we believe have to occur for the NHS to survive and thrive in the medium term. And although we're working on the wording, almost certainly one of those objectives will be the better appreciation and the accentuation of the role of health in the productive economy. And I just want to really identify 3 ways in which we need to think about that broad challenge. So the first is kind of paradigmatic. That is to say, we need a different paradigm for thinking about these issues. And at the heart of that is 2 very simple truths, which we understand, but yet are not part of our day-to-day reality and the day-to-day reality of policy making, particularly in Whitehall. So the first is this recognition of the value of the NHS to wider socio-economic goals. NHS is not just there to deal with our health, but it has much wider externalities, which can be negative, but also could be and can be and are positive, but could be much more positive. Secondly, the flip side of a recognition of the value of the NHS to wider socioeconomic goals is the relevance of wider socioeconomic policy to health. And the point I want to make about this, which is to reinforce something that Patricia said, is that I think that because of the complexity of that, understanding the contribution of health to socioeconomic goals, understanding the relevance of socioeconomic policy to health, at a national level, it's just too big and complicated to get your head round. And I think that Patricia's absolutely right that the enormous potential of ICSs is that it provides us with a scale where we can start to get our arms around those synergies and bring the partners into the room in order to start to develop a systematic account of the role of the NHS in the wider socioeconomy and a systematic account of the ways in which socioeconomic policy is impacting on health. So that's the first thing, a different kind of paradigm. And I think we're at the edges of that, but it's a critical challenge for ICSs to really bring that thinking to the heart of what they do. The second issue is kind of around policy and the policy priorities of the day, and the issue of levelling up is, of course, critical. And I think we are still in a bit of a battle, aren't we, to try to make sure that health is really part of the levelling up agenda. And I think we're going to see over the next couple of months how this works out. Andy Haldane is being brought in as a temporary permanent secretary to write the levelling up policy document. Now, Andy was previously chair of the Industrial Strategy Council, and I was a member of that Industrial Strategy Council. And two things I just reflect to the conversations we had there. The first was a bit of a push and a shove on that Industrial Strategy Council about whether industrial strategy was just about the kind of high-end, high-tech export industries, or it was about the foundational economy. And I think in the end, those of us who argued it should be about the foundational economy, where the vast majority of people actually work, that must be what industrial strategy is about, and not just the high-end export. I think we kind of won that argument, but I think it's still roiling around. And the second thing is the work we did on the Industrial Strategy Council about levelling up had a pretty powerful message for the government. It'll be really interesting to see how Andy reflects this in his work now, because what we found was those places that had levelled up, it took a long time, it took a large amount of concerted investment, and it took a huge amount of devolution to those places so that they really had the scope to do things differently. So levelling up is not going to happen by pulling a few levers and creating a few funding pots over the next 2 or 3 years. And it's incredibly important that the government is honest with us about that. And then the final point to make is, so it's about the paradigm, it's about the policy, but then it's just about day-to-day practice. And again, I think this is going to be important in terms of ICSs. So it's all the ways in which, when we think about NHS policy, we can think about the way in which that interfaces with issues are outside the health service. And I don't have time to go on those, but I'll just list a few. Sustainability, we've already mentioned, very important. Asset-based approaches, this is what I think Toby was talking about, which is the contribution the NHS can make through concepts of social value and community engagement. How does the NHS enhance the capacity of local communities economically and socially? The health on the high street agenda, how can we think about health facilities being part of the story of how we change and rejuvenate our high streets? Inclusive recruitment and good work. Good work was my big obsession before I came into the Confederation. And to take one particular angle of this, and I've nearly finished, I promise, older workers. So in some parts of England, people are retiring from work on the grounds of ill health in their early 50s on average. I mean, that is catastrophic. It's catastrophic for them in terms of their income, in terms of their well-being, because actually being out of work means you're more likely to be isolated. It actually means that their health is likely to deteriorate if they're out of work. And of course, it has a wider impact in terms of the fiscal situation, because they're then people who are more likely to be relying on benefits and less likely to be generating taxes. So that's just to take one aspect of how it is we support through flexible work and other forms of support. We enable people to stay in the workforce for longer. Planning and capital investment, as I think Toby said, the NHS is an enormously big part now of revenue and capital spending in localities. How can we make sure that that spending, that capital spending in particular, is done in ways which has wider positive externalities? And then finally, something we haven't really talked about, but really important, research, development, industry links, university links. The NHS can be critical as we try to develop R&D hubs outside London and the South East. So we need a different paradigm. We need to make sure that health is part of the policy priorities of the day, and levelling up is critical to that. And in just terms of our day-to-day practice, we need to see all those ways in which NHS policy can contribute to a wider set of objectives and vice versa. Thank you.
Thank you so much. And just one thing I wanted to follow up. When you talked about places that have experienced levelling up successfully but needed huge amounts of investment and also in many cases of devolution, just to clarify, what kind of places are you speaking of? I might guess.
So we talk about the Ruhr Valley in Germany, or we talk about parts of France, we talk about areas of America. In fact, I would recommend to people very strongly the Industrial Strategy Council, although it was apparently abolished accidentally, but that's a different story. The Industrial Strategy Council, before it was abolished, produced a really good paper on levelling up, which I think you can find somewhere on Google, and that looks at a number of places in Europe and in the States, and identifies these kind of 4 or 5 critical factors that seem to be common to those places that achieve this. But as I say, the big lesson is it takes time, it takes money, it takes proper devolution, and of course leadership is vital.
Thank you so much. We have so many good questions coming in, so I'm going to start with them. And for anyone who is thinking about submitting a question, use a Q&A tab, and all delegates can kind of vote on questions so we can prioritise the ones that you're most interested in getting answered. So the first one is from Peter Howie, Trust Secretary at Lincolnshire Partnership NHS Foundation Trust. Good morning. Could the panel offer any suggestions about how, as a foundation trust, we include our Council of Governors into ICS working to address health inequalities, particularly in influencing the wider determinants like housing, education, transport, rurality? Who wants to go first?
Well, I'll jump in just because I don't seem to be the only person who's not on mute. So, and also just to make myself popular with Patricia, Toby and Owen, I'll go first on this one. What I'd say is that there will be a wealth of understanding in those governing bodies in relation to these other dimensions that we've been talking about. So I think as we think about our governance, we need to think of people as not simply people who are overseeing what we're doing in health, but also people who can make these connections to other networks and other areas of work. But the other thing I'd say about this is I do think we need to get specific in this stuff. You know, there is a danger that we talk at a high level of generality. And I think it's going to be absolutely critical that ICSs develop specific programs of intervention. You can't boil the sea, you can't do all of this stuff. So choose, you know, each ICS should be choosing 2 or 3 areas. Maybe that's housing and health, maybe that's employment and health, whatever it might be. Maybe it's something specific, more specific, like doing something to increase older people's participation in the workforce. So identifying, looking at the assets you've got in terms of your governance, who are the people you know, where are the particular areas of possibility? We do need quick wins in ICSs. So identify places where there is potential and turn these principles into specific work programs which seek to be able to generate positive feedback as fast as possible.
Thank you. And who wants to come in next on this? Toby. And then Patricia, sorry.
Well, I slightly want to turn Peter's question around, because we do this in the NHS, don't we? We get to an agenda and then we invite people to come and join us. I mean, it's clearly important, and Matthew set that out. But, you know, how do we have people who work in the NHS in representation in housing associations as school governors? How do we give people time and support to be really immersed in the local community? I think that's equally a fruitful route to get to some of the things that we've been talking about so far in this panel. And that doesn't happen without a certain amount of willed intention. And I think all NHS boards can take a step in that direction by promoting those opportunities and offering some measure of time and recognition for that kind of community participation.
Patricia.
Yeah, I absolutely agree with Toby and Matthew, and the governors play a really important role in terms of their community engagement. They're elected, they're the outward face of organisations, and so they have connections into community that sometimes we don't have. And I think that they play a really vital role in that space. So in our ICS, our community and our governors have asked us to engage in a Poverty Truth Commission. That means that we already have one strategic aim to pursue as an ICS in the new environment from April onwards. So I think they play an absolutely critical role. And I really support Toby's view that just like in the private sector, we should be encouraging our NHS people to be involved in those community groups and reimbursing them to do that, because they bring a wealth of knowledge back into decision making within the sector.
Thank you. I don't know if Owen, you wanted to add anything, otherwise I'm happy to move on to the next question. Thank you. Adam Sewell-Jones asks, Patricia, in light of you transitioning to a new role, what are your hopes for what you can achieve as an ICS CEO that you and your colleagues haven't been able to do as CCG and provider CEOs?
I think that for me, the ambition that I think we will be in a better space to move towards is not just dealing with the 2 of the 4 strategic objectives that are entirely about the NHS, which are around productivity and unwarranted variation. The prize for me is how we deliver on NHS England's objectives, but actually that not being the primary focus of the ICS. It's how we come together as partners across health and local government and community to really, 1, drive down health inequalities, and 2, play the role that we really should be in social and economic regeneration. That's the big prize for me, and that's where our work needs to be focused. And I think the benefit of the legislation for the ICS is going forward is it's a very different conversation when people are collaborating because they are asked to, and it's their gift whether they do or not. And then transition into a space where actually they have to collaborate. That's a different conversation. And I think we have an opportunity in the new strategic objectives to craft a different vision for ICSs, where local government really do feel part of it. They're leading a good section of it, as opposed to what's happened in the past, where I think if we're really honest, we've asked local government to come to the table when they can do something for health, as opposed to it being a true partnership. So I think we have a real opportunity now to create a different environment of collaboration that could produce something really positive, where our community see ICSs as adding value to their lives.
Thank you so much, Patricia. That's really well explained. The other question, I think the housing issue is quite an interest about that relationship, as it's obviously such a huge factor in issues around inequality in health. Andrew Van Dorn, who's NED London North West University Healthcare NHS Trust and CEO of the Housing Association's Charitable Trust. Good to hear the panel speak about the importance of housing and their anchor roles. How far do they see a role for providers of social housing, such as housing associations in ICSs and provider collaboratives? Who wants to go first? Matthew.
Sure. I don't mind being the person who volunteers whenever nobody wants to speak. This is it's because I did my cold water swim this morning, so my brain is just going so fast. You know, I mean, I'm very, very, very cold as well. But look, I think housing associations. I've done a lot of work with housing associations in the past, and they are organisations with enormous potential in terms of the way in which the best housing associations relate to their tenants, not just in terms of bricks and mortar and housing services, but much more broadly. And I think, you know, there are lessons for us to learn actually in health service from the best housing, and I want to emphasise the best, but from the best housing associations who many, many years ago went on the journey of which we're now talking about, which is to say, if we want to help our tenants, it's not just good enough that we, you know, give them somewhere to live and that we do their repairs reasonably efficiently. We've got to think about employment and well-being and asset-based approaches. Many housing associations adopt those asset-based approaches. So I think, you know, any health leader locally who wants to kind of talk to people about how you pursue this agenda, if you've got really strong housing associations, engage them early on, because I think there are lessons to be learned. But I would say let's look about housing overall. Let's look, for example, at the critical issue of kind of planning gain. So if there are developments taking place within your locality, it's really important that health leaders are part of the conversation about how we make sure that those developments are done in ways which are good for housing, good for health. You know, that they've got spaces for activity, and also the role, talking about health on the high street, one of the things that I think we must aspire to in the future is that we disperse health capital much more widely across the community. About diagnostic hubs, for example. Well, those diagnostic hubs, they should be in. Why not have them in shopping centres, which might be the thing which gets those shopping centres to be thriving again. So let's think, broadly about the relationship between housing and health. But I think that certainly housing associations are a really good way to start that conversation, because I think they understand this language, and actually they have thought about the health of their tenants for some time.
Thank you. Did anyone else want to add on this? Otherwise, I'll move on to another question.
Tricia,
did you want to? Yes, please.
I absolutely agree. Absolutely agree with Matthew. Housing associations, they understand asset-based development. They're fantastic at it, and so working with them is really important. But I also think there's a broader question around, one, when local authorities plan housing developments, being realistic about what affordable housing actually means in terms of the economic stability of communities, not this governmental formula that bears no relationship locally to what affordable housing actually needs to cost. And also how the NHS uses its estate assets in this space. So an example is at my organisation, as part of our new hospitals programme, which we're in HIT 1, one of the things that we're building is affordable housing on our site, because we know that it's a real issue in our community. We know that the local authority are not going to be able to move forward at pace to solve a lot of those issues quickly. And so we've chosen to use part of our estate to do it. That not just supports the community, but it also supports local employment in bringing people to the west of Dorset, the rural community, where in reality, if we weren't doing that, they would not be able to afford to own their own home. So I think we've got a part to play in that broader agenda as well, in using our assets in different spaces to support community development.
Thank you, Patricia. And Toby, you wanted to add to this?
I think this issue brings home something I wanted to touch on, which is that the sequence with which we do things matters. So Matthew's surely right. We pick 2 or 3 things and focus on them. But actually the order in which they're done does matter. I mean, I've spent 25 years working homelessness services. And when you say now that it's obvious to give that housing comes first, people look at you like you must be rather odd because it's patently clear. So I suppose I think the Health Foundation are right to make the argument that there has to be a good reason for housing, fuel poverty, environmental sustainability, the making of place, not to be in that early list. And the risk, I think, is that it's in the longer term, too hard to do, don't start here category. And I think I would strongly make the case that it's actually the foundational logic of most communities where you live and how safe you feel.
You're on mute, sir.
Unmute. I was hoping no one would have to say that to me today. Matthew, you wanted to add something? Sorry.
I don't know if Owen wants to come in first. No. I just want to come back to Grenville's question, because I know we're running out of time, and I just thought it was such an important question about leadership. And when we talk about ICSs, the phrase that keeps coming back to my mind is something that Chris Ham said to me in a podcast.
We're not running out of time. We have got till 9:55.
Okay, right. Well then, all right. Well,
do you mind if I come back to it a bit?
I'm really sorry. I thought it was 9:45.
No, that's okay.
No, I will shut up and go away and be quiet.
You can put your little yellow hand down as well. Don't worry. We've got plenty of time. We're going to get to that question. There's a question that's coming specifically for you, Owen, which is from Jonathan Hodgkin. Could you give concrete example of how provider or system practices have exacerbated health inequalities? That's from Jonathan Hodgkin, NED of the Dudley Group.
Yeah, Jonathan, thanks for this question. And the answer is absolutely. There's a little bit of it that says, where do you want me to start? So, for example, when we were looking at elective backlog recovery, when we looked at that by ethnicity, for example, we identified that the average length of waits for patients under the certain prioritisation category, for example, prioritisation 2, that if you were white, you were likely to be having a shorter waiting time than if you were Black, Asian, minority, ethnic. Or, for example, if you were in the most deprived indices of multiple deprivation, say 1 to 2, you were likely to be waiting longer than if you were in the indices of multiple deprivation 9 and 10, which is least deprived. And equally, for groups, community patients, for example, with a learning disability, again, we were finding not only were they potentially having to wait longer, but if you take, for example, a woman with a learning disability is likely to live 18 years less than a woman without, and a man is likely to live 14 years less. If you treat that community of patients just as you would treat every other patient, then therefore you are in effect building in inequality through your practice. So certainly both at a organisational level in my previous organisation and also at the West Yorkshire ICS level, and certainly something I'm looking to bring in the organisation I'm in now and Greater Manchester, it was really to get to a situation where, for example, our board decided that anybody with a learning disability that was on the backlog list, regardless of the severity of their condition, would be fast-tracked. Equally, we really engaged with our clinical colleagues, not just within an acute setting, but also within general practice and so on and so forth, to really understand what was going on within the multidisciplinary practice to create these conditions. And again, I emphasize the point, these were things that were happening under our umbrella and weren't to do with external factors. So again, we worked hard, and there's nothing like putting in front of a clinician or a speciality their specific data. And when you show this information, for example, around ethnicity, learning disability, and index of multiple deprivation, it gets people to reflect on their practice. And I noticed, Jonathan, just finally, I would say that thinking about the Dudley area, because I just quickly Googled as fast as I could, you know, you've got 90% of the Dudley population is white. Associated Sandwell, that figure is 70%. I would have expected as a non-executive director that your board would have looked at backlog recovery in the context of that information to understand whether there's any differential across different groups. I would have expected your board to be doing that now. So just a thought process to reflect on, and I'd be happy to discuss outside of this forum.
Thank you so much, Owen. That's really helpful. Right, some more great questions. Karen Bentley, NED Walton Centre NHS Foundation Trust in Liverpool. Good morning, she says. Both Owen and Patricia have clearly highlighted the importance of people defining the services they need. I've seen this done in a very tokenistic way in the past when working with people with learning disabilities. Can the panel give actual examples of how involvement, inclusion, representation has driven concrete changes? I don't know if Patricia and Owen. Owen first, yeah. Go for it. And then, sorry, Patricia first. Your mic was already open, and then Owen. Apologies.
Okay. So I could give a couple of examples. In our system, we've developed front rooms for our mental health patients, and as a first line intervention when they're distressed, and that we co-designed that approach with them, worked on that whole principle with them. In the organisation I lead, we have embedded a policy called experience-based design and experience-based co-design. So what that means is that we regularly bring groups of patients in. They talk about different touch points of the service, what their emotional and psychological reactions to those touch points were, and then we redesign that pathway with them so that they get the best experience possible. We bring them back within 6 to 12 months to see whether those responses have changed in terms of the pathway changes that we've made. We're also now just building a first extension to our ED department as a precursor to starting the HIP1 development at the end of 2023. And we have given our patients the right to veto the design. So they regularly come and walk round. They have the plans at hand. And if we are about to make a change to those plans that they're not comfortable with, that won't enable them to have the best experience, particularly our learning disability community, then they have the right to veto and we go back to the drawing board. So it's those kind of things that make them front and centre of the decision.
Fabulous. Thank you, Patricia. Owen.
Yeah, so 2 areas I think I would say here. First of all, data and data collection. I know there's lots of provider colleagues on this conference. My challenge to you would be, when it comes to learning disabilities, what's the quality of data that you have, and not just about adults as well, children. So first of all, do you know your community of learning disability patients? And then therefore, do you also know their carers, their family representatives, and do you build up those relationships? Because through doing that, that's when you start to be able to, first of all, understand where the problems and issues are. But certainly in my experience, what we've been able to do is, for example, totally change the vaccination environment for patients with a learning disability, working with mental health colleagues, working with physical acute colleagues, community colleagues, to really change the environment. And, that really sounds really obvious, doesn't it? But actually, for a lot of people, it wasn't obvious. And it's only been belatedly that people have been adjusting their vaccination processes to really think about the totality of the experience for people with a learning disability. We've also done that with backlog recovery. And I just want you to think about this. If somebody has a significant or a severe learning disability, but they require quite a complex operation, for example, that means you have to think about planning and organising that. You have to think about how you will change your waiting list. You have to think about pre-operation, post-operation. What's the environment that person is going to come back around? Who's going to be around them? All those things require real attention to detail. And you're not going to do that unless you're working with the families and you understand what their needs are.
Thank you. I'm going to bring up a question from Grenville Page that, Matthew, I know you were keen to answer. This whole agenda has been talked about for many years, and you hear about the opportunity for the ICS to really bring significant change, yet another restructure of the NHS. But are we doing enough to significantly change the culture, behaviours and mindsets, and truly move away from the long-term silos across the public sector? And Grenville is NED. I haven't got the whole of the thing, but thank you.
So it's a great question, and as I said to the first meeting of our ICS network last week, what I quoted a couple of times was something that Chris Ham said, and Chris Ham said if ICS is going to work, they have to be institutions different to any others that we've created over the last 70 years in the NHS, and I think that's absolutely right. And we're bringing in some great chairs, fantastic chief executives already. But I think everyone who wants to be a leader in the ICSs needs to understand that this is going to require a different kind of leadership. And I think we need to think deeply about that, because ICSs are going to involve a combination of roles. They're going to involve, I'll be brief, but just say one element to that. On the one hand, there's all of this kind of convening and collaboration that we're talking about. But also there is an extent to which ICSs have also got a role in relation to a kind of accountability and challenge and regulation. How do you hold those two things in, how do you get those two things right? How do you engage with people on day one to really achieve change together, but then on day two ask them challenging questions about whether or not they're kind of performing at the level that they need to be performing at? So I would say that it's really important that while ICSs grind through all the governance and other stuff and all the kind of demands that are coming already from NHSE, that the leaders really give themselves space, and particularly with other ICS leaders. That's what we were trying to do with our network, to think about the nature of this leadership challenge. Because if you just apply, however great a leader you are, if you just apply the leadership skills you've got in the past to this new ICS challenge, then I think you won't be fulfilling your potential or the potential of the ICS.
Can I just tag something else onto it? And Owen, you come in next. Kirit Mystery says, how will we ensure greater diversity of patient and community voice in ICS? So that's part of it too, but go ahead, Owen.
Yeah, so I think there's a couple of things for me around that. There's no doubt already in this country, there's some really great leadership at the ICS level, where there's a bond, there's an understanding of the challenges, to Matthew's point, about recognising that the kind of organisational power-driven leadership has kind of had its day, is just not going to work in an ICS construct, which is really about influencing capability. But it's also, we have to hold our hands up and be honest about this. Within this country, there are also some ICSs that are just ICSs just because of a statutory requirement. And quite frankly, the relationships are just not good enough. And the leadership culture needs real development. So for me, my question is not really about what the latest, deck chair shuffle's about. It is really about, are we going to get serious about collaborative leadership and to understand that we're not all just born with collaborative leadership skills. It's something that needs to be honed and developed. And we need to start moving away from some of the more traditional leadership approaches and start to ask the question, what does good collaborative leadership look like? Not just for 2021, but for 2035. What do we need to move towards? But we do need to really be honest about, from my point of view, I've kind of had enough of those systems where it's really still about organisational sovereignty. People are all about protecting their thing. And it's time for us to grow up, move on and recognise that our communities need us. I feel very passionate about this, as you can tell.
Well, given that we're into the last 3 minutes, I'm going to ask all the rest of the panel, Patricia first, both to respond to that, and then any closing thoughts too, Patricia.
I agree with both Matthew and Owen. I think that the NHS spends a huge amount of its time in first order change. Occasionally it dips its toe into second order change, but it very rarely moves into third order change. And, even now with the ICSs, we're concentrating on structure, we're concentrating on framework and policy. What we need to concentrate on is to get our leaders to ask themselves, how do I need to be different in order to lead this change? And if we're all able to ask ourselves that question, then we can start to move into the development we need to do in order to deliver true collaboration and work alongside our communities. But that's where it starts, because we all have to evolve into different people when change is required. And the NHS needs to get into the habit of that being one of the core questions that it asks itself. And also that the centre focuses on that and doesn't just assume that leaders can morph into what is required every time change arrives. They need to think through how leaders need to be different and provide that support and challenge for them to be different moving forward.
Thank you. Toby next, and then I don't know who hasn't spoken. Matthew, have you spoken as well or not? I can't remember.
Well, I think my closing thought, I'm a great fan of the Stockdale paradox, which we haven't got time to explain, but broadly, absolute confidence that this agenda can be delivered, but absolute honesty about the situation we're in. And we've been in this situation and been at this agenda umpteen times, and that should mean we've learned something and are getting closer. But I guess that the step that will make this more likely than not for me goes back to something Owen said. I think the data is out there. The evidence is out there. We need to publish the data, and that will cause us to hold ourselves to account, but it will also enable communities to hold systems to account. So I think there's a be brave on the honesty of the data and publish it, for all that lived experience is important. This is a quantifiable agenda. If we haven't shifted the who in terms of who we're in contact with, then in 2 years' time, we haven't learned, but we can.
Thank you. Matthew, you were the last one.
Sorry, I'm very happy to say something which I very rarely say, which is I've got nothing to add.
Cool. Thank you.
It's been a great session.
Well, can I just say, I think it has been a great session, thanks to everyone's questions. And thank you all for giving both the concrete and the kind of more general observations. I just wanted to end by a point that Ibrahim Ismail from Liverpool University Hospitals Foundation Trust says, absolutely spot on, Patricia, and Wigan is a great example. We've had the big society in Northern Powerhouse, so he is naturally sceptical about what makes levelling up different to those of us who've seen many initiatives but not much change, and you've very much confronted that challenge for the NHS. So thank you so much to all my panel. And if you